So the topic I have is cardiac amyloidosis, a diagnostic algorithm. Oh, here it is. It is right. So amyloidosis is a protein misfolding disorder. Normally, our proteins are in a three-dimensional tertiary structure. Whether it be a mutation in that protein or some kind of oxidative modification, it can pathologically misfold into a more linear structure in a beta-pleated sheet formation, which can further fragment, aggregate, and form amyloid fibrils, which are not soluble in blood. They deposit extracellularly in tissues and cause dysfunction. Under electron microscopy, these fibrils are very distinct. They're about 8 to 10 nanometers in diameter and also are non-branching and rigid. And all amyloid fibrils contain calcium and some glycoproteins within that mesh, including the precursor protein. There's been over 25 amyloidogenic proteins described that cause various diseases depending on the precursor protein that misfolds. But as a practicing cardiologist, we only have to familiarize ourselves with a few. AL amyloidosis, which used to be termed primary, is a clonal plasma cell disorder in the bone marrow that overproduces an amyloidogenic light chain. This disease is multisystem. Cardiac involvement is in about 30 to 50%. And when it is involved, the prognosis is poor if untreated, with a median survival of 6 months. Senile cardiac amyloidosis, which has been changed to senile systemic amyloidosis, or SSA, because there are deposits in other organs apart from the heart, is due to the precursor protein transthyretin, or TTR. This is secreted by the liver. Cardiac involvement is universal, and carpal tunnel syndrome is common. This is a more indolent disease with a prognosis of about 5 to 7 years. ATTR is a hereditary form of transthyretin amyloidosis. In this case, there's a single amino acid substitution in the transthyretin gene, and depending on the mutation, there can be significant heart involvement. AA amyloidosis, due to chronic inflammatory conditions or chronic infections, rarely causes cardiac involvement, less than 5 to 10%, and in 10 years I've only seen 2 cases. And isolated atrial amyloid is due to atrial natriuretic factor that misfolds and deposits in the atria. This can be seen in elderly patients. Again, not very clinically relevant. So I basically boil it down to these 2 types. So when I see an echocardiogram or a suspicion that I'm dealing with cardiac amyloid, I simplify it. I'm either dealing with a plasma cell clonal disorder that's over-secreting light chains, or transthyretin that is secreted from the liver, misfolding and depositing in the heart, whether it be wild type, as in senile cardiac or SSA, or mutant in familial amyloid cardiomyopathy. Just a very brief mention about TTR. It used to be called prealbumin. It's secreted as a homotetramer, and in wild type or SSA, deposits mainly in the heart, and if there are mutations, it can also affect the nerves. This is a much more common disease than we initially recognized. There is a mutation in African American V122I that's highly prevalent, 3.5%, and wild type or senile cardiac amyloid is not that uncommon. And Matt Maurer and Rick Ruberg will talk about this much more in detail. When amyloid affects the heart, it does so in a diffuse manner, unlike patchy diseases like sarcoidosis and myocarditis. There's diffuse involvement of the left ventricle, the right ventricle. You can see deposits in the atria and the interatrial septum. It can also affect the conduction system, the valves, and even the pericardium. The first clinical clue you're dealing with amyloidosis is the parasternal long axis of an echo. This thing is not working. But anyway, over on the right, you can see that there's septal and posterior wall thickening. You can even see some RV free wall thickening. And of course, this correlates with the pathology. So in addition to the echocardiogram, the electrocardiogram can give it a very important clinical clue. So the combination of the echo and the EKG is extremely important. And the classic EKG is that of low voltage in the limb leads and a pseudo-infarct pattern in the precordial leads. And again, combining this with the echo increases your suspicion. This is a 55-year-old male who presented with heart failure and nephrotic syndrome. This is a not-so-subtle echo where you see very significant thickening of the septum and posterior wall, and RV free wall thickening. So thickening of the RV is a very important clue. Here you can see the valves are thickened, and in the apical forechamber, direct your attention to the atrial septum, you can see thickening there. which can be a specific clue in the setting of biventricular thickening. This gentleman's EKG did not show low voltage, but I would say he has relative low voltage. So based on what we would expect for someone with, let's say, hypertrophic cardiomyopathy or hypertension, this voltage is lower, and he ended up getting biopsied and had AL amyloid. This is a more subtle case, 72-year-old white female with heart failure and atrial fibrillation refractory to ablations. In this case, the wall thickening is not as profound, but she has very little longitudinal motion, and the clue here came from the very low voltage in the limb leads and a pseudo-infarct pattern. She had AL amyloidosis as well. So clinical clues or echocardiographic clues are biventricular thickening, atrial septal thickening or right atrial free wall thickening, diastolic filling abnormalities, but this is not specific to amyloidosis. So you can have anywhere from stage 1 to stage 4, and that will not help differentiate with most diseases. The classic EKG with low voltage in the limb leads and pseudoinfarct pattern in the precordial leads is only seen in 50% of patients with AL and only a quarter of patients with transthyretin amyloidosis. So the absence of low voltage should not dissuade you from moving forward with a workup. And in fact, in one study, 7% actually met LVH criteria with TTR. These patients present with congestive heart failure, sometimes with predominant right-hearted symptoms, HFpEF, AFib, pacemaker due to complete heart block, or angina with normal coronaries. And depending on the type of amyloid, you can get other systems involved, nephrotic syndrome and orthostasis, neuropathy. Macroglossia and periorbital purpura are specific for AL, and bilateral carpal tunnel syndrome is very common in senile cardiac amyloid, usually precedes the diagnosis by 5 to 15 years. This is an example of macroglossia specific to AL, as is periorbital purpura. So you have a suggestive echo, suggestive EKG, and a clinical findings that may support this diagnosis. What's the next step? Is it a fat pad biopsy? Is it a bone marrow biopsy? Now these have decreased sensitivity depending on the type of amyloid. The money is usually to biopsy the affected organ. In this case, the heart. Endomyocardial biopsy is a relatively easy procedure if you've done many. We go from a transjugular approach, and we take about 4 or 5 pieces, hopefully from the septum and not the RV free wall. I quote patients a 1% risk of RV perforation leading to tamponade. On pathology, you see this diffuse amorphic pink staining material on H&E, which is the amyloidosis, and in this case, high-powered view, there's almost no myocytes left. This is more subtle in the intercellular spaces, but it has a characteristic appearance on H&E. However, you have to confirm that with a specific stain that binds beta-pleated sheets, and that's Congo red for the most part. What you see on polarized microscopy, apple green birefringence, which confirms amyloid deposits. We use thioflavin S at our institution, which again has the same concept. So H&E may suggest it, you confirm it with a stain, but what's very, very important is the pathologist has to type it. They have to tell the clinician, are we dealing with transthyretin TTR, or are we dealing with kappa or lambda? And then the bottom right there, you see immunohistochemistry, which we use at our institution, and most of the time we can type the amyloid, and if not, we send it for mass spectrometry to confirm the type. So the diagnostic approach we just discussed is to go straight to an endomyocardial biopsy. If it's kappa or lambda, you get a hem-onc consult. If it's TTR, you get genetic testing and decide if it's wild type or SSA or if it's mutant. However, there are other approaches to going after the diagnosis. You can start with some simple lab tests, and then there are non-invasive modalities that can be very helpful: cardiac MRI, echo with strain, and technetium pyrophosphate. Quick mention about lab testing. The most important labs to order are serum free light chain assay, serum immunofixation, and urine immunofixation. They have about a sensitivity of 99% and a very good negative predictive value if negative. Do not order an SPEP and UPET. This is too insensitive a test, yet this is what basically the majority of patients are ordering. I'm just going to repeat it again. Do not order an SPEP and a UPET. The serum free light chain assay basically measures the free light chains in the serum, and it's very useful for diagnosis. Here's a normal value for kappa and lambda and a normal ratio, and the ratio is important. And here's a case very abnormal. You see the kappa is very high and the lambda is normal, so it can help determine the type as well. Cardiac MRI is quite useful. You obviously see the thickening of the LV and the RV, and you can actually measure interatrial septal thickness. But the gadolinium enhancement pattern is very characteristic of amyloidosis. There's a diffuse subendocardial enhancement, and you can also get enhancement in the atria and the right ventricle, and it doesn't correlate to any coronary territory. And again, here's another example of this diffuse subendocardial enhancement pattern. Sensitivity is about 80%, specificity about 90%, and an 85% negative predictive value. So a normal MRI doesn't exclude the fact that you could have amyloid. 55-year-old African-American female with angina and normal coronaries. In this case, you can see in the little arteries, there's diffuse amyloid deposits, and it's localized there, and not so much in interstitium. And this lady had lambda AL amyloidosis, and her MRI was negative. Relative apical sparing on longitudinal strain. So our group and others have noted that when you do longitudinal strain, there's a characteristic relative apical sparing. So if you look at this echo, you get the sense this is an amyloid patient, that the apex is working better, and then the mid, and then the base progressively worse. And when you apply longitudinal strain, you'll see near normal or normal strain at the apex, and it gets worse at the mid and even more worse at the base, and you get this characteristic bullseye appearance on the polar map, which helps differentiate it from other forms of thickening or hypertrophy that does not have this, such as hypertension and hypertrophic cardiomyopathy. Another non-invasive test that's very useful is a technetium pyrophosphate or dipyrophosphate scan. These are nuclear bone scans, and it was observed that mainly in TTR cardiomyopathy that there's diffuse uptake in the heart. And you see there on the left there's a patient with hypertrophic cardiomyopathy with no uptake. You have a patient with senile cardiac amyloid and hereditary TTR with very significant diffuse uptake. This is a slide using SPEC from Matt Moore's group. You can see HFpEF, there's no uptake, AL, really no uptake, and a lot uptake in TTR. So it's pretty specific for TTR, although there are patients with AL amyloidosis who can have mild to moderate uptake. So when you are encountered with a clinical situation where you have significant thickening and you're wondering about amyloidosis, the EKG can be very helpful, and these lab testing and non-invasive modalities can point you in the right direction. So in this case, this is hypertrophic cardiomyopathy, hypertension with renal failure, lysosomal storage disease, and amyloidosis. And again, differentiating them, you need to use your available different tests. So 63-year-old African-American male with recurrent heart failure. This looks very much like amyloidosis. It even has that speckled pattern. This patient also has low voltage in the limb leads. He underwent at an outside institution a fat pad biopsy and a renal biopsy, and they were both negative, and they felt comfortable that he didn't have amyloid. However, we biopsied him, he had transthyretin amyloidosis, and the key learning point here is a fat pad biopsy may not pick up the disease. In this case, there's no renal involvement in this particular type of amyloidosis. He underwent genetic testing and had the V122I mutation in transthyretin that can commonly be seen in patients with cardiac amyloid who are African American. He had a heart transplant in 2008 and is doing very well. So depending on the mutation, you have different ages presentation. So the V122I mutation's onset is around 65 to 70 years, so it's pretty much like senile cardiac amyloidosis, a late onset disease. Here's a 78-year-old African-American female with hypertension and EF of 45%, referred for shortness of breath. Here you see no low voltage, and you can argue LVH based on AVL and a PVC. She's 78 years old, and she's African-American female, and that's what heightens my suspicion. You can see her echo shows some biventricular thickening, thickening of the valves, biatrial dilatation. If you want to hallucinate, some interatrial septal thickening. We sent her for a technetium pyrophosphate scan, and she had diffuse uptake in the myocardium. She had normal light chains and serum fixation. We sent genetic testing for TTR, and she had the mutation. This lady did not want a biopsy, and between all her clinical variables and her testing and her genetic testing, I felt confident enough to tell her she had hereditary transthyretin amyloidosis, and we offered her children genetic counseling. The red flags, any white male who's around 70 who has LVH and low voltage or has a pacemaker, and in particular has a history of bilateral carpal tunnel syndrome, I'm thinking senile cardiac amyloidosis. And elderly African Americans who quote unquote have hypertensive heart disease or HFpEF and thickening out of proportion to their valve disease or hypertension or low voltage EKG, I'm thinking V122I, transthyretin cardiac amyloidosis. Elderly patients with HOCM. So I didn't show this case in the interest of time, but we're seeing more and more patients come with HOCM physiology. We do a myectomy, and it comes back TTR. So the pearls here, you need a high index of suspicion. EKG and echo forms your basic framework. Non-invasive testing can be helpful. Echocardiography with strain, technetium pyrophosphate scan, and cardiac MRI. Do not order an SBEP and UPEP when you're screening for AL amyloidosis. That is not sensitive enough, and you need to do the free light chains and the serum and urine immunofixation. And again, wild type or senile cardiac amyloid, always ask for a history of carpal tunnel syndrome when you're suspicious about amyloid. And again, with African Americans, think about the V122I variant. So at the end of the day, if you know that you're basically almost 95% of the time dealing with either AL or transthyretin, then you know what to look for. So the EKG and the echo with or without strain gets you in the right direction. Ordering the AL screen can virtually exclude AL amyloidosis if all are negative. Technetium pyrophosphate is quite specific for transthyretin, and obviously a cardiac MRI can be useful, and ultimately endomyocardial biopsy for the definitive diagnosis. And it all depends on what you want to do with each specific patient, whether you go straight to a biopsy or do these other tests. I thank you for your attention.